Guests and delegates, welcome to the second edition of the Rajasthan Neuroscience Update, organized by the Department of Neurosurgery in collaboration with the Department of Anatomy at All India Institute of Medical Sciences, Jodhpur. The department was in its infancy when it hosted the first Rajasthan Neuroscience Update in 2019, a stage when the department had just 3 OTs per week and the struggle to arrange for sufficient emergency operating time. Today, the department has grown and has 2 dedicated and fully equipped routine operating neurosurgery theatres and 1 dedicated emergency OT that is functioning 24 hours for emergency neurosurgical cases. This year, the organizers have set a theme for the conference so as to facilitate a more in-depth and comprehensive discussion regarding the topic. Like the Greek mythological figure Atlas, who was condemned to shoulder the weight of the heavens, we take this as a privilege to have the opportunity of hosting you all this weekend, and we hope that the next 2 days will be an academic feast for neurosurgeons and neurosurgical trainees in understanding the nuances of the craniovertebral junction and C-spine. We have already started with the cadaveric dissection workshop and the Johnson & Johnson workshop in the morning, and we now move to the academic lectures. The first session deals with the fundamentals of the craniovertebral junction and CV junction trauma, and I invite the esteemed chairpersons for the session, Dr. Suresh Nair, Dr. Hemant Bhartiya, Dr. Pushpinder Khera, and Dr. Abhinav Dixit. May I please invite you to the stage. The speakers for this session will be Dr. Bansal, Dr. Sarbesh Tiwari, Dr. Mahesh Gadhvi, Dr. Deepak Gupta, Dr. Kiran M, Dr. Gopal Krishna, Dr. Rohan, and Dr. Sushil Patkar.
People will come. Okay. Because, say if you can start in time, probably everything will go on time. Otherwise, start, no? People will join, no? Okay. Okay. I think at the outset, I should thank Deepak and colleagues for inviting us to this great meeting. And we had an excellent, it's going on still, a cadaveric workshop. It is done by Noopur. And what an excellent show he's doing there. And now we have the scientific program, and we have to start the scientific program. And it is on fundamentals of CV junction anatomy and CV junction trauma. And that if you look at the program, we have a galaxy of speakers, who are talking on anatomy to radiology to IONM to mythology also. And then we have some clinical experience, Odontoid talks and all. And with this brief introduction, I think I will ask my co-chair to invite the first speaker.
Yeah, good morning, everyone. And as Dr. Suresh Nair has already introduced about the program to this session, that how rich it is, let us start with the first talk of Dr. Bansal on anatomy and ligaments of the craniovertebral junction. Dr. Bansal is senior consultant neurosurgeon at Narayana Hospital, Jaipur. Dr. Bansal, please.
Thank you, sir. Thank you, chairpersons, and thanks the AIMS team to organize this great meeting, and thanks for inviting also. In the morning, there was a cadaver dissection and teaching of the CV junction and subaxial spine fixation. Good morning, respected chairpersons and the audience. I want to talk about basics anatomy. As we know, the ligaments in the CV junctions are as important as the bones are. The craniocervical junction is a distinct osteoligamentous entity with the specific functions and demands, as we all know. And the understanding of anatomy of the CV junction is of utmost importance to correctly diagnose the pathology and further helping the management. So this is basically a osteoligamentous complex. We should call it as an osteoligamentous entity. So the bones are tied with each other by the ligaments as we tie bamboo to knit a roof or to support like this. I took the picture because the construction is going on in my hospital. So these are the ropes are like ligaments, and how we fix the bones with the ligaments in our body. So the small video of the bones, like of the atlas and the this is the how the condylar joint and the atlantocondylar joint is like a cup and a saucer. It is curved as we think that it's not a straight one. So the movement at the anterior posterior is more than the lateral movements at that atlanto-occipital joint. It's almost 25 degree in the anterior posterior and only 5 degree in the lateral. And then C1, C2 is this is the superior articular process of the C1 or atlas, and there is medial tubercle, and how the dens fits into the in between the lateral masses and the posterior arch, and then this makes the C1 C2 joint, which is also an angular joint, anterior posteriorly, and the oblique joint rather than angular. So we have to be careful while operating with this area of the body. So this is having a unique anatomy, the craniovertebral junction, which represents the complex transitional zone, because the cranium and the spine comprises of balance of bones and ligaments. It is composed of osseous structures, which is articulated with the joints and intrinsic ligaments and the membranes and muscles. It not only houses the spinal cord or the CV junction or the pontomedullary junction, and then down the cervical spinal cord and with the multiple cranial nerves, and it protects them and support them also. So the bones involved here are on 3 bones: the occiput, atlas, and the axis. This is the unique complex that includes the occipital condyles, C1, C2 joint, and several major and minor stabilizing joints, ligaments, which between the skull and the upper cervical spine. So we should know a little bit of embryology also, that the craniocervical junction is a mesodermal origin, and it develops at the around 3rd week of gestational period. It develops from the mesoderm, it separates into somites. The somites give rise to skeletal musculatures and the column, vertebral column. The somites differentiate into sclerotom. The occipital bone develops from the 4 occipital somites, and the upper cervical spine, like C1, develops from the 3 cervical somites. So the first cervical somite and the 4th one of the occipital somite makes the proatlas. The typical apical proatlas is the apical segment of the dens. So the most important ligaments are almost 7 or 8. They are variables. In some cadavers they were found, in some cadavers they were not found also. So the from anterior to posterior, if we go, the superior anterior atlanto-occipital ligament is the first one if we go from anterior.
and then anterior atlanto-occipital membrane, then atlanto-occipital capsular ligament, apical ligament, and the most important is the cruciform ligament. Then tectorial membrane, LR ligaments, and posterior atlanto-occipital membrane. Then there are few accessory cranio-cervical junction ligaments are also there. So this is a basic
anatomy which shows from anterior to the anterior superficial atlanto-occipital membrane, then anterior atlanto-occipital membrane, which joins from the anterior arch of the atlas superior part and then goes to the clivus. And there are all ligaments shown here which continue below the C1 arch as a anterior longitudinal ligament.
So this is the superficial membrane. It is a very thin midline ligament. It's running anterior to the anterior atlanto-occipital membrane between the basion of the clivus and the anterior tubercle of the C1. It gets taut when we do the hyperextension and get lax when we do the flexion. So, but it is a very low tensile strength than the LR ligament and the transverse ligaments, and it is located posterior to the longus capitis muscle. So the second one is the anterior atlanto-occipital membrane. It is densely woven broad ligament that fans out bilaterally from the midline and runs from the anterior margin of the caudal clivus and insert on the anterior arch of the C1, the whole. So the it's located and immediately posterior to the longus capitis muscle and superficial atlanto-occipital ligament, and forms the anterior boundary of the supradental space. It prevents the hyperextension of the C1.
It is seen as a very thin membrane in the MRI section. If we see, it's a very
dedicated MRI. So then the capsular ligament next to that is the condylar C1 joint, which is the analogous to the, if we see, it's a teacup like resting on a saucer. The ligament, which I shown in the bone in the first slides. So the entire joint space is enveloped by the tough capsular ligament. It maintains significant contribution to the CV junction stability. So the abnormal joint space widening or subluxation or the front dislocation of the condylar C1 joint implies underlying injury to the capsular ligament. Then the apical ligament. It is a very thin midline ligament running in the supradental recess between the basion and the bony tip of the dens. It arises from the dens anteriorly and goes up to the clivus. It's found in the anterior atlanto-occipital membrane and posteriorly the superior band of the cruciform ligament in between that. It does not contribute significantly to the stability, and it may be absent in 20% of the cadaveric specimens. Then the most important ligament which holds the dens in position and makes the CV junction stabilize is the strongest ligament is the cruciform ligament. It is a cross-shaped ligament, and it's a superior and inferior band and the cross band also, transverse band also. And then it holds the dens in the proximity to the anterior arch of the C1. It's maintain the integrity of the C1 atlantodental area. The superior longitudinal band ascends to insert on the basion, and the inferior longitudinal band descends down center to the ligament to insert on the posterior body of the C2 joint, C2 body. The transverse band plays a vital role in maintaining the C1, C2.
You can see the anatomical dissection. This is the cruciate ligament. The anterior atlanto-occipital or the tectorial membrane posterior to this ligament has been removed. We are going from posterior to anterior. So this is the transverse band and this is the vertical band which holds the dens in position here. So, and this arises from here in the bilateral medial tubercle of the C1, just medial to the lateral mass of the C1, and it inferiorly it inserts on the C2 body, and superiorly it goes up to the basion.
So the injury to the transverse band is of the cruciform ligament is implied by the abnormal widening of the atlanto joint space.
So if we see, look from this superiorly, this is the cruciform ligament. This is the longitudinal band and this is the transverse band goes down. This is the dens, and from here the other ligaments like the apical ligament and bilateral LR ligament, which fixes the dens in position also.
So this the next one is the tectorial membrane deeper to the cruciform ligament. It is only 1 millimeter thick. The superiorly it extends to the extension, it is superior extension of the posterior longitudinal ligament. Posteriorly, it adheres to the dura mater superiorly. The inferior extension of the tectorial membrane to the C2 body. And this is also a major stabilizing ligament. So when we see the this thing of tectorial membrane tears on MRI, this has been divided into four types. Like type 1 is retroclival stripping injury, type 2A and B is subclival disruption of the at the basion, and down is 2B at the odontoid level. Type 3 is thinning or stretch injury to the tectorial membrane. So then the next ligament is the LR ligament. It is a paired ligament, is superolateral dense to medial surface of the occipital condyle. And it is a major stabilizer of the dens or the CV junction. The medial occipital condyle, when ruptures, so there is a type 3 fracture, then it gets disrupted.
So this is again, we can see the same picture again. These are the LR ligaments which goes superiorly and attaches to the medial part of the occipital condyle. This is the lateral mass of the C1.
So then comes the another thin fan-shaped membrane is the posterior atlanto-occipital membrane. It's a broad fan-shaped midline ligament. It runs between the posterior C1 arch and the posterior margin of the foramen magnum. It is the superior extension of the ligamentum flavum and diffuses laterally with the atlanto-occipital joint capsules. It prevents the hyperflexion and impingement of the atlas on the cord. Then the accessory ligaments of the CV junction. There are few craniocervical ligaments that have an inconsistent presence in different cadavers. Sometimes it is present, sometimes not. It is then the anterior atlanto-dental ligament and the transverse occipital ligament. So these are the major important ligaments of the CV junction, which makes the CV junction stabilizes. So I'm cordially invite all of you for the next year neurotrauma conference in Jaipur from 4th to 6th August. To all of you. Thank you very much.
Thank you, Dr. Bansal, for wonderful overview and beautiful pictures of the anatomy with the ligaments, which is so important. If anyone has any question, or Dr. Jitendra, because he's from anatomy, to make some comment.
I'm actually from radiology. So, sir, Dr. Bansal, you have taken us through very well the anatomical delineation of the region. And if there are no questions, we can directly go to the next lecture, which is actually going to be an extension of this. Dr. Sarbesh is going to describe the radiology. And I think then we can have some questions.
Yeah, okay.
Thank you, sir. So I now invite Dr. Sarbesh. He is an associate professor in the Department of Diagnostic and Interventional Radiology here at AIIMS Jodhpur. And he's a neuroradiologist, having done his DM from NIMHANS, and will be talking about the radiology of the CV junction. Over to Sarbesh.
Good morning, everyone. So my topic is the extension of the previous topic. Dr. Bansal has described most of the things in detail. We will be seeing the same things from CT and MR perspective. So as we have seen, this craniovertebral junction is a very unique and a complex anatomical structure. And it consists of joints, bones, and ligamentous structure which provides a transit from the cranium to the spine, and it kind of provides a covering to the very vital cervicomedullary junction. So it's unique in the sense that it does not bear disc. Like most of the spine, it's a disc which bears a weight, but here it's a synovial joint that does the same thing. And it exhibits significantly more movement as compared to the other parts of the body. When you talk about, it's like a ring on a pivot. So here the C2 vertebra and the basic occiput is the stand or the pivot, and the ring is the lateral portion of the basic occiput, the condyles, the opistheon, and the atlas ring. So these are the three structures that we've already seen: the occiput, This is the occipital condyle, the first cervical vertebra and the second cervical vertebra. And these three structure primarily constitutes the the craniovertebral junction. So this is the brief CT anatomy here. If you talk about certain points which we should know while reporting a CT scan, this is a SAG image. This is the tuberculum sella. This is the dorsum sella. This is the clivus. This point that you see here is the posterior margin of the hard palate.
Sarbesh, can you just activate the pointer?
Yeah. Okay. So this point that you see over here is the posterior margin of the hard palate. This is the anterior arch of the atlas. This is the odontoid process, the posterior arch of atlas. Now, certain points are important because we have to do certain measurements. These are based on these points. And this is the coronal image. Here you see this is the swan neck-like thing, that is the jugular tubercle. This cleft over here is the hypoglossal canal. This is the occipital condyles, the lateral mass of the atlas, the body of the atlas, and the odontoid process. The same anatomy is depicted on X-ray here. Now, X-rays are very important in the operating room. This is what you have on the screen most of the time, or the CT if there's a PACS available. So this is the certain point, the tuberculum sella over here. This is the anterior arch of the atlas. This is the posterior arch of the atlas, and they are better seen in this image. Now, before I move on, we should know a little bit about the embryology. So the CVJ is basically derived from 4 occipital somites and 3 cervical somites. Of this, the first 2, it forms the clivus. This is the clivus area. The third forms the occiput, which includes the condyle and the region of the jugular tubercle. The fourth occipital somite is the most important one. It is called proatlas because it forms what actually forms the articulation between the occipital bone and the atlas. The tip of the odontoid process, the lateral masses of the C1 vertebra over here, and the occipital condyle. These 3 important structures are derived from the proatlas. Then the body of the odontoid process, the anterior and posterior arch of the atlas, is derived from C2, and the C1 somite, and C2 and C3 forms the cervical second and the cervical third vertebra. So these are the occipital condyles, and we have seen it in the skull specimen as Dr. Bansal has shown, and in the CT this is how it appears, and it articulates with the superior surface of the lateral mass of the atlas. Anteriorly, it will be lined by the hypoglossal canal. There are certain variations that we should be knowing in anatomy. You can have sometimes the precondylar tubercles, a third occipital condyles, or sometimes a calcified ligament of odontoid process of the axis, which may be mistaken as a pathology. The atlas, it's the only vertebra without a body or a relationship with an intervertebral disc. So this is the CT image of atlas. It looks like a ring, and it is kind of related to the dens of the axis. The second vertebra, it has an odontoid process. It has a superior articular facet which articulates with the lateral masses of the atlas. It's a unique vertebra. The superior extension dens, which has an articular facet actually, it articulates with the anterior arch of the atlas, and then there are 2 other processes, lateral masses, which articulates with the lateral mass of the axis. Coming to the ligaments, the ligaments are grouped into 2 headings. They're the intrinsic ligaments, which are intrinsically involved in the joint formation, and the extrinsic ligaments, which are outside the joint premises. Coming from inside outwards, tectorial membrane, cruciform ligament, and odontoid are the 3 important intrinsic ligaments that we should be aware of. So we see in the schematic diagram, the innermost is the tectorial membrane, followed by the cruciate ligament. This is the apical ligament, the part of the odontoid ligament, and this is the outermost, or the extrinsic ligament, which is the anterior atlanto-occipital membrane. The tectorial membrane is basically a continuation of the posterior longitudinal ligament. This is the posterior longitudinal ligament. At C2 vertebra and at the clivus, it becomes the tectorial membrane. And this is in the coronal, this is like a fan-shaped ligamentous structure. So it runs posterior to the cruciform ligament, and it prevents a hyperextension injury. Cruciform ligament, this is how it appears, like a cross. It has a transverse ligament which fixes the dens to the posterior aspect of the anterior arch of atlas. It has a superior crust and the inferior crust. This is the coronal representation, and this is the SAG representation. This is the transverse ligament, which is actually attached to the tubercle of the atlas. And this kinds of holds the dens like a seat belt so that it does not have any translation, anterior or posterior translation. So it's a major stabilizing ligament. And if you see, this is a T2 space image, a high quality T2 image, where you can see this hypointense ligament, which is seen coursing posterior to the odontoid process, and it is attached to the tubercles in the atlas vertebra. Now, moving ahead, odontoid ligaments. So this is the apical or the suspensory ligament. It attaches the tip of the dens to the opistheon, and it is not a major stabilizer. Then we have the alar ligaments. So these are paired structures which extends obliquely from the medial aspect of the odontoid process, and it attaches medially to the occipital condyles. So this limits excessive rotation and lateral flexion. So if you see in MR, this is the same image. This is the odontoid process. This is the odontoid, and you see these two black dots here. So these are the alar ligament. They can be seen on high quality T2 images, and then you can see them getting attached to the medial aspect of the occipital condyles. Then extrinsic ligaments, they are the minor stabilizers of the CV joint. Anteriorly, you have the anterior atlanto-occipital membrane, which prevents a hyperextension injury, and posteriorly we have the posterior atlanto-occipital membrane, which prevents the hyperflexion kind of injuries. And then we have the joint capsules. They are the major stabilizers again, the atlanto-occipital and the atlanto-axial joints. They can be properly seen in the high quality 3D T2 and merge images. You can see the joint capsule here. This one over here is the atlanto-occipital joint space, and this is the atlanto-axial joint space. It is important because in pediatric population, sometimes what we see is just fluid in this area, which may represent us a injury, or there may be instability. And the muscles as well, the longus colli muscle over here, they are also a minor contributor to the stability of the CV joint. They prevent hyperextension of the neck. So there are multiple craniometric lines. If you can see, there are a host of them. We have put 10 over here, and there are multiple, but few of them we should be aware of. One of them is the Chamberlain's line, where we draw a line from the posterior pole of the hard palate to the opistheon, and generally the tip of the dens is below or up to 3 mm above this line. Anything above 6 mm is considered as basilar impression. The McRee's line, it is basically a line connecting the anterior and posterior end of the foramen magnum. The tip of the dens does not exceed this line, and if the sagittal diameter of this line is less than 20 mm, it is called as foramen magnum stenosis and may have neurological symptoms. The Walcher's basal angle. So here we draw a line from the nasien to the tuberculum cellae to the basian, and the angle here is around 137 degrees. It doesn't cross 140. If it crosses 140, it is considered as platybasia or flattening of the skull base. The Wackenham line, it extends, it's a line drawn along the clivus into the cervical canal, and you will see the tip of the odontoid process not violating this line. And there is a simple index called the height index of Claus, which is a distance between the tuberculum torcular line to the tip of the odontoid process. This is normally around 4 centimeter or 40 to 41 millimeter. Anything less than 3 centimeter is considered as basilar invagination. We have two more indices here. We have the atlantodental interspace, which is around 3 millimeters in adults and 5 millimeter in children. Anything more than that is considered as atlantoaxial instability. You have the lateral ADIs also. Now, lateral ADIs may be variable, particularly in pediatric population, but if the difference between these two, the right and the left ADI, is more than 2.6 millimeter in a traumatic background, it should be considered as a feature of instability. So in the next 3-4 minutes, I'll just move around the imaging part. So we do take radiographs, CT inflection and extension views, and when taking MR, it is important to acquire a 3D T2 image and a 3D merge image to give a good anatomical depiction of the CVJ. And if you're doing a CT angiography of the neck vessel, is always helpful to know the relationship of the vessels with the craniovertebral junction. So just moving ahead, like seeing some of the anomalies. So anomaly of the occiput. Here, if you see this particular case, there is a very short clivus. Rather, it's a pneumotized sphenoid sinus you see over here, and there is a very hypoplastic clivus over here. This is the C2 vertebra. This is the odontoid process. There is fusion of the axis with the occipital bone, and the occipital condyles are hypoplastic. So this is a basi-occipital hyperplasia. Another case, there is flattening of the skull base. You see, this is called platybasia. The Welcher's basal angle is 152 degree, which should be less than 137 degrees. Basilar invagination is when you can see the vertebral column or the odontoid process is abnormally high, and it is seen indenting on the brainstem. So they can be primary, like it's developmental, or secondary due to metabolic bone disease or other conditions. So in this case, the odontoid process will be deviated above the Chamberlain's line, more than 5 millimeter above the Chamberlain's line. Anomalies of the occiput. So this is a case of condylar dysplasia. Basically, this is a persistent of proatlas. The tip of the odontoid, it attaches to the clivus, and this is an example of condylar dysplasia. Malformation of the atlas, the most common of them is the atlanto-occipital assimilation. You see this example over here. There is fusion of the lateral masses of the atlas to the axis vertebra, and this is secondary to failure of segmentation between the fourth occipital sclerotome, that is the proatlas, and the first spinal sclerotome. You see some variations, and which may be problematic when you're dealing with a traumatic case. Like in this case, this is a posterior arch rachis. You see a midline non-fusion of the posterior arch of atlas, and this is reported in around 4% of cadaveric specimens. They are mostly midline and they are asymptomatic. In contrary to the posterior arch anomalies, the anterior arch anomalies are rare. They are around 0.1%, and when they are combined with posterior arch anomaly, it is called a split atlas. In this case, you can see an anterior arch defect as well as a posterior arch defect over here. There are multiple odontoid anomalies, of which the os odontoideum is very important. You have an independent osseous structure which is lying superior or cephaloid to the C2 vertebral body in the area of odontoid process. They are usually round, well demarcated, well corticated, with a hypoplastic odontoid and an hypertrophied anterior arch of atlas. So they can be orthotopic when the anatomy of the os is maintained with the anterior arch of atlas, and dystropic when it is migrated toward the clivus or attached to the clivus. You can have sometimes odontoid aplasias and hyperplasias. They're extremely rare. So this is one such case where you see that this is the C2 vertebral body, and you literally have no odontoid process. This is the corneal view. This is the C2 vertebral body, and this is just a peg of odontoid that you are seeing over here. And this kind of anomaly, they predisposes to atlanto-axial dislocation. In this particular patient, we also had anterior and posterior rachis or a split atlas. Atlanto-axial instability. So in this case, if you see the distance between the arch of the atlas and odontoid process is around 8 millimeters. So this is an example of atlanto-axial instability. So there is a definite role of flexion MR in CVJ. So this is an example showing how a CVJ anomaly causes impingement of the cord. So this is a flexion image where the retroflex odontoid process is impinging on the cervicomedullary junction, and as you move ahead with extension, the compression is relieved. So I think I have only one more slide. I'll just complete it. And there is an important role of doing vascular imaging in CVJ. Definitely, you have to plan your procedure, you have to plan where you're going to fix the screws and everything. But there can be certain anomalies also which can lead to problem. Like in this case, you have a basilar invagination with a kissing carotid artery. You can see, so it can be problematic for the surgeon, and it is nice to be aware that such anomaly exists. Further, CVJ anomalies are associated with vessel anomalies as well. Like in this case, there is a severe basilar invagination with atlanto-occipital assimilation. That is fine. But if you see the CT angiogram, you see that the right ICA is also hypoplastic, and there is non-development of the left ICA. So CVJ anomalies are associated with developmental vascular anomalies as well, and hence a vascular imaging is mandatory. To conclude, cross-sectional imaging plays an important role in diagnosis. CT helps in delineating the bony anatomies, and MR has become the imaging modality of choice. Dynamic MR, whenever possible, should be done to see the kind of cord compression that we are talking about. Thank you.
Thank you, Dr. Sarbesh. Any questions from the house? Yeah, I can see Mathuria, sir. Sir, please go ahead.
There are two comments.
Yes, sir.
One is that you told about that this is for the residents. One, you told about the distance at the atlanto-axial joint,
Yes.
atlantodental distance.
Yes, sir.
This distance is okay, but sometimes what happens that there is a mobility. Though the distance is 1 millimeter, when you do the flexion, the distance increases to
Yes, sir.
3.5 millimeter.
Yes, sir.
We recently had such patient. In that mobility is given a importance also.
Yes, sir.
It's not, somebody should not say that the distance is 3 millimeter. It's not 3 millimeter. Distance is 1 millimeter and it has increased to 3 millimeter.
Yes,
So
sir.
that is one if the patient is symptomatic. And the other thing is, if you see a AAD on routine neutral X-ray, don't advise, this is again for the residents, don't advise for the flexion extension like that. Do the flexion in front of you if you need to have it. See that the patient doesn't have any problem. Then you get the flexion done at that this much movement only, which the patient actively does. No passive movement is permitted. So that's what is the thing for the residents. I think Sarbesh will agree to me on
Yes,
that.
sir. There's no doubt about it, sir. Yes.
Okay, thank you.
Yeah, please go ahead.
It's really the question of MR scans in atlantoaxial rotatory subluxation. How do you distinguish? Can you use the distinguish between a instability and something that requires surgery, or something that will respond to just a conservative management? I mean, what's the status of the ligaments? Can you see that on the MRI scan?
Yeah, like I have shown some images like merge sequence. So merge is basically a 3D gradient image, and you have a PDFS. So the spontan density fat suppressed images are very good for depicting the ligamentous anatomy. Let me try and show you this particular image over here. So actually you're able to delineate the ligaments on the MR images. So it is possible to delineate the ligaments on the current MR technology. And if you have a 3D image, then the different measurements can be taken, which shows instability or what is there.
So no question but comment.
Yes, sir.
We neurosurgeons try to fuse it. Wherever there is, reduce it and fuse it. I wish someday we would like to, we would focus on the ligaments. And like orthopedicians do ligament fixations in knee, we can do that also. And one thing was excellent that you showed lateral displacement, which many of us don't consider or see, try to see. Thank you.
Thank you, sir.
Actually, I think the vascular anatomy which you have shown,
Yes, sir.
it's an eye opener. I think you don't lose anything now. Now it is not the DSA. CT angio can give you all the information. I think when you are dealing with such complex lesion, you don't lose anything in doing a CT angio. And even 1% problems you may face with, that also will be avoided.
Yes, sir.
That's very nice. Thank you.
Regarding this ligaments, most of the radiologists, they do gradient sequences because they are the earliest to acquire. But that really does not show you the ligaments. So what you should always ask is to ask them to do a PD, proton
Yes, sir.
density,
Yeah.
and the medic sequences.
Yes, sir.
Because these are the sequences, you will see the ligaments very well.
Yeah, so this particular image,
Absolutely, yeah.
Yeah, it's a PD fat suppressed image which
yeah.
demonstrates the ligaments.
Good.
Thank you, Dr. Sarbesh, for a wonderful lecture. We'll now go on to the next speaker, Dr. Mahesh Gadhvi, and he's going to talk about intraoperative neuromonitoring in CVJ surgery. Dr. Mahesh is Assistant Professor of Physiology at AIIMS Jodhpur, and he has special interest in IONM. Dr. Mahesh.
Good morning all. Myself Dr. Mahesh Gadhvi. After seeing anatomy and radiology, now let's see how physiology can help in CVJ surgeries. So first, intraoperative neurophysiological monitoring. This IONM, it gives real-time feedback information to the surgical team. The functional status of the neural pathways under surgical manipulation can be monitored through IONM. Now in IONM, we have monitoring and mapping. So it attempts to minimize neurological damage during surgery, which is monitoring, and by IONM, we can confirm neural structures on the operating field. Now in IONM, there are different modalities which are motor evoked potentials, which is MEP, somatosensory evoked potential, which is SSEP, electromyography, brainstem auditory evoked potential, which is BERA, cortical and subcortical mapping, language mapping, and triggered EMG. But in case of CVJ surgeries, mostly we use MEP, SSEP, which is motor evoked potential and somatosensory evoked potential. Until now, in IONM, we did more than 300 cases, and for CVJ surgeries, we did more than 40 cases of CVJ surgeries. Now, in CVJ at AIIMS Jodhpur, when there is chances of damage to the brainstem or spinal cord, lower cranial nerves or upper spinal nerves, or vertebral artery and its branches is there, we do IONM. Common pathological entities in which we performed IONM is congenital malformation of CVJ, Arnold-Chiari malformation, traumatic injuries to CVJ, intramedullary tumors, or vascular malformation. The risk of developing new neurological deficit is related to two principal steps. First is positioning of the patient, and second is surgery itself, means surgical manipulation. So positioning of the patient is very important during CVJ surgeries, and when during CVJ surgeries, it might require that the patient is turned into lateral or prone position, or the neck is flexed or extended, which can cause spinal cord compression or loss of neurological function. So intraoperative neuromonitoring can play an invaluable role in alerting the surgeon to a new impairment in spinal cord function, and commonly we saw that promptly repositioning of the patient allows spinal cord function to return to normal. Now in IONM, mostly in CVJ cases, we do motor evoked potential and somatosensory evoked potential. Now let's see what is MEP and SSEP. So MEP, in MEP we do transcranial electrical stimulation is applied over the cortex. We give current through the cos2 electrodes. So these electrodes which are placed over motor cortex, according to 10-20 system, we apply the electrode on C3, C4 or C1, C2 position. After applying electrode, we give current, and this pathway is monitored through the muscle because it is MEP. So we apply subdermal needle electrodes in different muscles. In different surgeries, the chance in which muscles they are getting damage, we apply electrodes, but in CVJ surgeries, we apply electrodes on all the muscles of upper limb and lower limb, all 4 limbs. So after stimulating, we get this kind of response. So in this image, you can see there are different waves. Each wave represents each muscle. So the first one, uppermost, which is recording from deltoid muscle, then brachioradialis, abductor pollicis brevis, and abductor digiti minimi. The upper 4 represent upper limb muscles, and the lower limb we record from quadriceps, tibialis anterior, and abductor hallucis muscle. So after recording this, we take this recording baseline. So just after induction, we record this when the muscle relaxant's effect is gone. We take this recording and then we compare this baseline with the recording which we get after positioning or during surgical maneuvers. So this recording, it is taken during surgery or during surgical manipulation. So what we check? So in the first image, you can see on vertical axis, it is amplitude. So we check the amplitude of baseline, and then we compare this baseline with the subsequent recordings. The guidelines which we follow for MEP are American Society of Neurophysiological Monitoring, and the alarm criteria is amplitude decrement of more than 50%. Means if the amplitude is decreased more than 50%, then only we tell the surgeon that there is some neurological trauma. Okay. Now in transcranial MEP, there are some advantages, like it is relatively simple in generation and recording. So within seconds we get recording and we can inform the surgeon about surgical manipulation. But there are some disadvantages, like it is highly vulnerable to inhalational anesthesia. So if MAC value, which is minimal alveolar concentration, if it is less than 0.5, then only we get MEP. If it is MAC value is increasing, then MEP amplitude decreases with the increasing MAC value. The muscle relaxant cannot be given, so anesthetics mostly give total intravenous anesthesia in the form of propofol. The precautions we must take during MEP the first which we encounter in our institute is muscle power. So preoperative muscle power must be checked. We saw that if the muscle power, preoperative muscle power is 3 by is equal to 3 by 5 or less than 3 by 5, we don't get MEP. And if it is 4 by 5, in only 50% of cases we get MEP. So preoperative muscle power must be checked before doing MEP. The second is bite block. So in MEP, twitch happens throughout the body and there is chances of tongue bite. So bite block must be applied. And there are some parameters which can change motor yoke potential, which is mean arterial pressure. So blood supply to the spinal cord, bispectral index, which is depth of anesthesia, and temperature. So hypothermia can also change MEP. We can also do electromyography in the form of free running EMG, continuous EMG, and triggered EMG. So if there is any damage to the neurons, we can get this kind of response in the muscles, which signifies that there is nerve irritation. And if we want to check the nerve or if we want to identify the nerve, then we can stimulate the nerve and we get recordings. It is called as triggered EMG. So after motor yoke potentials, let's see what is sensory yoke potential. So somatosensory yoke potential, it is just opposite to MEP. In MEP, we were stimulating on the motor cortex and we were getting responses from the muscles. But in somatosensory yoke potentials, we stimulate peripheral nerves. In upper limb, we stimulate median nerve, and in lower limb, we stimulate posterior tibial nerve. And we get recordings from the sensory cortex. So we apply subdermal needle electrodes on peripheral nerves, median nerve and posterior tibial nerve, and we get recording from the sensory cortex through corkscrew electrodes on the scalp. SSCP has some advantages over MEP, like it does not provoke unwanted movements of patient during surgery. So in MEP, we have to ask to surgeon that we are going to do MEP, and that time he has to stop the surgery. But in SSCP, we can do SSCP without informing the surgeon. Muscle relaxant can be used in SSCP, but SSCP only sees or only monitors sensory pathways. So in CVJ cases, we have to monitor both sensory and motor pathways. So it is we do MEP as well as SSCP in all the cases. And SSCP takes time. In MEP, we get responses within seconds, but in SSCP, we have to take averaging of 300 to 1000 waves. We take some time to inform to surgeon. Now in SSCP, we get this kind of response. In response, you can see on the vertical axis, it is amplitude, and on the horizontal axis, it is latency. So we have to check both latency as well as amplitude of all the waves. On the left side, it was normal SSCP, but on right side, you can see the red, in red color, it is baseline, and we compare the baseline with subsequent recordings. So you can see the amplitude is decreased in these cases, which might be during surgical manipulation. So what are alarm criteria in case of SSCP? So amplitude decrement of more than 50% or latency increase of more than 10%, it is significant change, and then only we inform surgeon. This was about SSCP. There are some special consideration for IONM, and it is TIVA, total intravenous anesthesia. So a combination of propofol and opioids are given, and inhalational anesthesia and muscle relaxant cannot be used during IONM. In IONM, clinical neurophysiologists do monitoring, but it consists of all the parts, surgeon, nursing, anesthesia people, all are helping in neuromonitoring. And we follow the protocol, like preoperative history is taken and all the muscle power we check. Then our setup where we inform anesthetics and we apply electrodes, software settings are done. Then we do evoke potential, and post-operative history is also checked whether they are significant with the intraoperative findings. This was all about intraoperative neuromonitoring in CVJ cases. I want to acknowledge Department of Physiology, Department of Neurosurgery, and Department of Anesthesiology of AIIMS Jodhpur. Thank you.
Thank you, Dr. Mahesh. We all know that this is such an important aspect in this particular surgery. Are we using this in AIIMS?
Yes, sir.
The neurosurgical team
Yes,
is
sir.
doing it regularly?
Yes, sir. I was sharing the experience of our institute only.
So that's a wonderful asset, I think. if there is any question.
What a lovely talk. I was sitting there and recording your talk. Lovely talk. And always, the thing is, poor monitoring is better than, is worse than no monitoring. So we told that just because one, say, fool with a tool is still a fool, no? So he told the importance of the teamwork, where neurophysiologists, neurologists, anesthetists, they all should be there for monitoring this thing. And what I want to tell you is, it has, it is a very costly procedure, these equipments and all. So in US, there's some guidelines came where they told, actually, it is, it cannot, it can predict neurological injury, it cannot prevent.
Yes, sir.
And they told it is not cost effective. So they cannot put it as a recommendation for using it. So basically, it was done to protect the surgeons who do CV junction, because there it is mandatory. They should not make it mandatory that one who does all this surgery should have this monitoring. So to protect them, only they told, no, it is not necessary like that. But actually, it is very much necessary, so you can always, withdraw or do some sort of corrective measures if this wave starts dipping, and which you correctly told. Any other comments? So it is in future. This is going to stay only. IONM will be there to stay, and there cannot be any class 1 evidence study, because you cannot compare two groups. One you do not monitor, other you monitor, and that is still now not possible. So you have to have your old studies with the present studies and compare that. There will never be a class 1 evidence. So I think absolutely it is going to stay. It will protect the spinal surgeons, and I do this intramedullary tumor surgery. It is a very important rule. Any other comments? Mathuria sir?
Can there be any cheaper modality available where indigenously made or whatever it is? Then probably this can be used at more places.
Sir, you can do some modalities like electromyography you can do, but all these modalities in one equipment, it is not available. But you can do EMG and triggered EMG if you want to monitor nerves, or if you want to map the nerves, facial nerve or other cranial nerves.
No Indian-made things are available which are cheaper than what you are using.
Sir, we don't found, because we want to give current in high volt. So it is recommended that FDA approved machines should be there.
Okay.
Otherwise, sir.
Okay, thank you.
Thank you, sir.
This is one-time investment, sir. So consumables are very costly for electrocorticography, not for spine monitoring. So the cost is somewhere from 25 to 60. 60 is the best available now, and 25 is quite good machine. We have got both the machines, and for spine monitoring, the consumables cost is negligible. So same consumables are being used. So this is one-time investment and must be used. So we are having these people who are helping us in preventing our complications for last 4 years.
So the patient has to pay here this much of money?
No, it is part of the surgical charge. So actually, there is no consumable that is used for that particular patient. The same consumables is used for many patients.
So we move on to the next paper.
Thank you, sir.
By Dr. Deepak Gupta on Hindu mythology and odontoid fracture. And it would be very less to say that Dr. Deepak Gupta is professor at AIIMS and in charge of the pediatric section. Everyone knows about Dr. Deepak Gupta's work on conjoined twins and craniofacial figures. Not only in India, he has been teaching abroad, and I think maybe live surgeries also he's been doing there for this complex problem.
Respected Chairperson and the August gathering, it's a proud honor and privilege to be at this podium for the first time. I congratulate Deepak for organizing this meeting. And I just saw Dr. Atul Goyal entering the hall. And what a nice way to give this talk in front of him and to seek his thoughts. Well, I've taken the liberty to change the first two letters of my talk from Hindu mythology to Hindu beliefs. And I'll be briefly touching upon some neglected aspects of odontoid fractures. I mean, when you look at the Wikipedia, the first thing you will see is the Hindu mythology. And there it's very clearly written, Hindu mythology is a body of myths and literature attributed to and espoused by adherents of Hindu religion found in Hindu text. And this goes on to include our epics of Mahabharata, Ramayana, and Puranas. I think it's more of a European and the Western centric opinion, in my personal understanding. Because if you look at the scholars like Max Muller, Griffiths, Burton, they didn't call it mythology. But it's more of a so-called evangelist, those who promoted Christianity, the political leaders and the common man, they called it a mythology. Many of you must have read this Iliad and Odysseus epic by Homer. This has been equated to our Mahabharata and Ramayana. And if you look at the size is almost 1/200 of what is our epics are like. They were actually the mythology, not our epics. There is no question about that. This word actually came by the Greeks, means mythos. And probably this so-called Nordic Anglo-Saxon English people, they actually took it further to myths, which actually is a construct, in my understanding, to denigrate other religions. And actually, this word mythology was used to describe superhumans. Many of you must have read this story of Hercules, son of Zeus and Almene. It's also weird, in my understanding, to equate the legend Kalidas as Shakespeare of India. I would rather rate him as Shakespeare as Kalidas of West. This is how it should be projected like. The Greeks and the Romans, they did not consider exploits of their gods as myths till Roman Emperor Constantine actually converted to Christianity. And actually, after that, the Christians started denigrating gods of Greeks and Romans. You might have heard about this Parthenon, the Greece Athena temple, which is actually destroyed both physically and spiritually. My understanding is we should replace the word Hindu mythology by Hindu beliefs. Our epics are more of a living spiritual and philosophical treatise and not mere fictional stories. Puranas and Itihas, they should be used as nouns like Dr. Atul Goyal, Deepak Gupta or Deepak Jha. We are nouns and they need to be pronounced in equivalent. There is no equivalent word in English for them. Yesterday, one of my fellow, he took me to this Nepali Baba temple. And on the top of that, I saw this beautiful Shri Siddheshwar Mahadev temple. I'm not sure how many people who are staying in Jodhpur have actually seen that. And yeah, this is actually a Shivling. We do have a series of 64 Jyotirlingas in our country, out of which 12 are called as Mahajyotirlingam. And we know the story behind it. Each Jyotirlinga represents a conglomeration of Brahma, Vishnu, and Shiva. Now, if you look at it very closely, the Shivling, or the Brahma, Vishnu, and Shiva, exactly looks like C2 or the axis. The three powers, the Trinity power, and if you just extrapolate it to what we have in our body, the odontoid or the C2 axis actually has got three development phases. It has got three waves of ossification. As you can see in the picture out there, it has got a membranous phase, cartilaginous phase, and the bony phase. And these are the various centers of ossification which come out. And I think one of the images that was shown was of the lower and the upper synchondrosis which is there. So there's so much of similarity, I mean, in my eyes, between Shivling and axis. If you go and, those unfortunate ones, I would say, but many of us, we witnessed this during the COVID times. I too had this personal anecdote of losing my mom that time. So during this Asti Sanchaya, or the so-called Hindu ritual of collecting bones after cremation, the next day when you go, the person who's helping you in collection of the bones, he gives you a very specific vertebra. And he calls this vertebra Atmaram. Atmaram is nothing but the seal of conscience. And when he handed over that vertebra to me, I mean, in his language it was Atmaram, but for me it was a C2. And that is where I started thinking, is there a correlation between the three of them? Now I'm just portraying in front of you the three images, the shivling on the left, one of the picture taken from Dr. Atul Goyal's book on the axis, and on the right is the anterior posterior image. They look exactly replica of each other. So I always say that one cannot ignore axis when alive, Atmaram when dead, and odontoid fractures when injured. Anterior odontoid screws, we do left in and left out for many, many years, almost 95 to 100% fusion rates. Our Indian odontoids, they are not suited for two screws. There have been many studies done, and we have found that only one screw suffices because the size of the dents is not adequate enough to take two odontoids if you take 4.5 mm screws. Any surgeon or neurosurgeon who is attempting to go into fixations, he must be well versed with all the techniques. Let it be anterior, posterior, even up to the extent of occipitocervical fixations. And for the tomophobics, I mean, halo brace is an option, but yes, we have got very, very high non-union rates. We all know about it. This was a case which was very popularly circulated in the newspaper, media, and as somebody rightly said, a fool with a tool is still a fool. And this was a very simple, straightforward odontoid with the recently purchased O-arm in that time, 2010, which we had, and a screw was put, but this is what that happened to the patient 3 years down the line. This patient had got tal injury, which was missed, and then I required this. So I think tools are more of an adjunct. You have to use your kind of clinical acumen and skills to give the right outcome to the patients. Screw pullouts, failure to get adequate lag effect is not something very uncommon in odontoid screws, and we need to be very aware about it. This is my only complication. I must have done more than 100 odontoids in last 12 years. But horrifying complication. In 2011, two brother and brother-in-law, they both were operated the same day. And there was some problem with the infection in the OT that day. And both of them got infected. And whatever I did, it kept on getting infected. For 7 years, they were under my follow-up. And you name a surgery that was done for them, to the extent of doing a occipitocervical fixation. The infection can be a real killer in such cases. This was a young girl, I think 7-year-old girl. She had odontoid screw fixation, but she never woke up. And the CT that was done up, it shows evidence of subarachnoid hemorrhage. Well, the explanation is very simple. We then went back and tried to look at what really happened during our morbidity meeting. And we found that the K-wire had actually over-penetrated in one of the shoots. So I'll be just briefly touching upon the very common neglected aspects of the odontoid screw fixations. The first and the foremost, I would say, is missing out transverse ligament ruptures. As our previous speaker rightly pointed out the importance of ligamentous injuries. We need to be very clear, if this ligament is ruptured, it's an absolute contraindication for anterior odontoid screw fixations. Apart from that, if the person has got concomitant injuries of C1, C2, instability, then again is a contraindication for the odontoid screws. Sometimes you miss out coexistent injuries, especially in polytrauma setups. Many of these patients, you just look at the cervical spine, but they have got associated dorsal spinal trauma also that needs to be picked up. Some of these patients have got other injuries. Of course, the extradural hematoma takes priority over the EDH. These are the TAL injuries which have been missed in some patients. You need to study the radiology pretty well and clearly before offering surgery. The obliquity, I would say the anterior oblique fractures is a relative contraindication for anterior odontoid screw because they tend to pull the dents anteriorly, sometimes if it is not adequately and correctly placed. You need to check upon the reducibility. Dr. Mathuria rightly said, in any patients who has got AAD, you must do it in front and it has to be active testing for the mobility, not the passive. Older times, people used to do 2 C-arms, which I would say used to decrease the radiation, but now we are doing conventionally with a single C-arm, wherein we need to take more shoots, AP and lateral, and sometimes we resort to the O-arm. This was a very interesting study, sir. We carried out in AIMS many years back on the O-arm. And the number of shoots, you'll be surprised. An average surgeon was taking 100 to 150 shoots for one odontoid screw fixation. 100 to 150, AP lateral, you just keep on taking. And this is a hell number of shoots. In a straightforward freehand screw fixation, dorsal lumbar trauma, we don't take more than 10 to 15 shoots for the entire surgery. We often tend to ignore the surgical positioning. You have to ensure that the fracture segment is adequately reduced before doing the screw fixations. The role of the assistant is extremely important in this surgery because he does a lot of retraction for the screw fixation, and this needs to be checked. Handling the K-wire again is extremely important. You must know how to handle your K-wire. The K-wire should not over-penetrate, and when you have gone through the distal segment, you must pull out the K-wire. And sometimes the K-wire does break, and sometimes it goes further at times. The lag effect, nobody talks about it. The distal threaded tip of the odontoid screw should be in the distal segment, not in the intersegmental fracture gap. That's a basic physics principle. If that tip is not there in the distal segment, you will never ever have a lag effect. I'll show it in one of the videos of my at the end if my time permits. And at the end of the surgery, you must do a flexion extension view to confirm your stability of the screw fixations. Screw length has to be selected adequately before time, and you must know how to come out of the difficult scenarios. And whenever in doubt, I think it's always safer to do a posterior approach, let it be a transarticular or Goel's technique or C1, C2 fixations or whatever you have. But whenever there's some anomalies with you or you are not comfortable, you don't get the right trajectory, please don't think twice. Just go ahead and shift prone the patient and do the surgery from the behind. So this is a little experience, a couple of publications from our center, and this was a part of my PhD thesis topic, which I think I was in touch with Dr. Goel also that time when I was writing my thesis with IIT on craniovertebral junction. So to summarize, I would say there is some analogy between C2, Atmaram and Shivling in our Hindu kind of belief. And surgically speaking, for neurosurgeon, I think we must start concentrating on the attaining lag effect for and fusion because they often go hand in hand. I think I'll just run the video because I've got 1 minute with me just to show the young people how the odontoid screw fixation is to be done. This is one of the patient. That's defining the prevertebral area. You stay in between the two longosculi. The longosculi tend to converge as you go higher and higher up. And that's landing your trocar and cannula. I usually don't drill the C3 superior. That's a cannulated drill being positioned. That's to go from inside the body, not from the entry level mark. Otherwise, you tend to cut through. K-wire is being drilled. That's a trajectory from the undersurface of C2. Now it is being tapped with a drill. This video I'm showing just to show you what actually is the lag effect. You will see it very shortly. So you first put the K-wire and then you drill. This is with a handheld pneumatic drill, electric drill. Size of the screw to be inserted in the odontoid. Normally in Indian patients, we require between 36 to 40 now you see, 2 millimeter. The segment, the distal segment is getting pulled. That's the lag effect. As you tighten the screw, the distal segment has to come down. And for this, the tip is that the distal tip has to be in the distal segment. 3D fluoro Thank you so much. Showing.
Thank you very much, Deepak. From the chair only. What humility personified, honest talk, Deepak. And telling about the complications you had and also teaching us how to avoid this complication. Congratulations for this great lecture, Deep. And it's open for some comments, questions. Please, Atul.
Deepak, that was a wonderful lecture. You see, this simile with shivling, is very interesting, and absolutely the divine nature of odontoid process you have brought out. This Atmaram relationship, you know, when you said your mother died, you got this bone. My father died, I got this bone. And that time I realized that all the bones are burnt, but odontoid process
not burnt.
remains.
So,
You know why it remains?
I mean, I've tried to look up and read about it. I just could not come across. I looked at the cortico-cancellous portion and how much is the cortical, how much is the cancellous. I did not get any answer, sir. Maybe you.
See, odontoid process and disc have similar function. Odontoid process and disc. All the muscles are attached away from, there is not a single muscle going towards the odontoid process, not a single muscle going towards the disc. So in one of my articles where I have commented on your odontoid fracture article, if you have read, I had given a small commentary in that paper, Neurology India paper, where I had said that odontoid process is like rickshawala. He drives the rickshaw. In Calcutta, you know, the rickshaws are the two wheels and the man pulls the rickshaw. He's not so strong to pull heavy weights on his back. It is the design of rickshaw that makes him pull the rickshaw. And the big wheels of the rickshaw are the main, you know, he just holds it and just runs with the rickshaw. So I had called that design of the rickshaw is important. Odontoid process is like brain. It is not brawn. Brawn means muscles. Muscles act on the facets. Odontoid is the brain. Without the rickshaw wala, the rickshaw cannot run. But rickshaw wala does not run the mechanics of the whole system takes the rickshaw. You understood what I said?
Yeah.
The odontoid process is one small little bone. The entire field of medicine is afraid of that bone. The whole craniovertebral junction is focused on how this small little bone is compressing on the cervicomedullary junction. But this bone itself is divine, as you said, Shivaling. Shiva will never harm a person. We have to understand what has harmed the person. And it is not the odontoid process. It is not the compression by odontoid process. It is not the disc which is compressing. Disc and odontoid process they have divinity in them. They can never harm the person. We have to identify what has harmed, what has gone wrong, and we realize that it is the human body. Like we have not exercised enough, we have not made our neck strong. You will find that odontoid fractures are usually in thin and lean people, not in strong and muscular people, no matter how strong is the accident. So the odontoid process is an absolutely unique bone that you have brought out. We must realize that there are so many things in mythology, and particularly Hindu mythology, that we have to learn and correlate with our science, and we get so many lessons. Today what you have said is that there is Shiva in odontoid process. You must remember that Shiva will never harm the human body, which Shiva himself has made. You understood what I'm saying?
Yes, sir.
So when we are going to treat Shiva, the maker of the human body, we have to realize what has gone wrong. In my estimation, Shiva can never go wrong. In my estimation, disc can never go wrong. What is gone wrong has to be identified. In any case, Deepak, that was a beautiful. I like such talks, you know it, and you must go on interpreting mythology with these kind of things.
I use the word Hindu beliefs, not mythology.
Thank you very much, Deepak.
Thank you.
Great talk. We have to move ahead. And let me invite Kiran from Bangalore. He was a senior consultant at Narayana Hridayalaya. At Bangalore, he has moved to Chinmaya Mission Hospital in Bangalore about a week back. Kiran, the floor is yours. He's going to talk to us in lessons learned from managing a difficult craniovertebral junction.
Thank you, August audience, and Jodhpur team for putting up such a well-organized conference and a well-thought-of program. We started off with anatomy and physiology and moved on to mythology. Now let us come to real story. This is art story, which is all in black and white. And of course, as our previous speaker, Dr. Deepak, has put it, this is not just science, it is art, it is philosophy, and perhaps it is spirituality, because CV junction has always been baffled and nemesis. Like Maya, if you understand it, you can appreciate and reach the ultimate enlightenment, otherwise you will suffer. So just like this highway you are seeing, the nearest left turn may not lead you to the right path. Similarly, what is thinking like as Professor Atul Goyal has put it, what is obviously seen like compressing dens may not be the real pathology. If you go after it, you'll land up in trouble. And many of us learned this hard way. Of course, I was lucky because we had guide to teach us. First, let us learn from this patient. He was a 19-year-old man. He came with occipital headache and ataxia and difficulty in swallowing. And we, as everybody saw, the dens was compressing. And here, what had happened was, the right joint is symmetrical. Each case is different. There's no uniform, you can never say that, okay, this is how it is. And whereas the left joint was almost perpendicular as we see it. And there was assimilation also. And what was a challenge before us? Is it really related to C2-C1 junction only? We will see it. Then we did classically what we follow, distraction, realignment, and fixation. Then patient improved. But after some time, he came with worsening of the swallowing. He was okay, but he came with worsening of the swallowing. And when we did a MRI, we could see the compression is still there, and I'll explain it further. Then what was causing the compression? We were surprised. We thought that, as usual, the nerves may have been pressed at the CV junction and may be causing the compression. We decided to do a swallowing study. Once we did a swallowing study, we knew the culprit. It was not the CV junction, it was the hyperlordosis at the subaxial spine, which was causing the mechanical compression. So once we went back and studied, then we found out because the partial reduction and compression was still persistent, and the laxity of the ligaments, that is beyond the dens, there was a subaxial laxity and hyperlordosis which was compressing. And so we extended our fixation right down to the subaxial spine, and patient is doing now well. He is almost more than 10 years before this surgery has been done. He is all right. So this is how the post-op images looks, and this is how it has been corrected. And he's a priest in a, today we are having a lot of belief and other things. He's a priest in a temple. That is also a Shani temple. We all should be careful of, and he's doing well. So the lesson learned is key attention to the anatomy and stability and optimal reduction also. And we may have to look beyond CV junction. This is another case of a CV junction anomaly. If you see here, what has happened is, here, this is not a one-time process. Here what has happened, there is an initial CV junction abnormality, then somewhere in the early life, there has been some trauma added to it. So if you see, the whole C2 is fractured and it has moved. It is not just a CV or classical CV junction anomaly. I'll prove it. Like what has happened, similar here, the whole C1 has distracted because of some fracture early on, and it has settled off the occiput with the C2. Why I am telling is, in the joint, if that is C1 and C2, one will be concave and another will be convex, whereas here, both was concave. So this is how it is. And if you see in the laterals or sagittal plane, This was how it was. So if you see the reconstruction in the sagittal plane, this is how it looked. And even intraoperatively, this was how the joint was oriented. So there is multiple anomalies, and based on this, we need to plan the surgery. And this patient did well after the surgery. This is a post-op image. And these are the various spectrum of bony anomalies we can see, whether it can be occipitalized atlas, where the issue will be eye and inaccessible C1. So you may have to include occiput and vertebral. The vertebral anatomy will be variable, and so you have to be careful. Or sometimes absence or destruction of C1, narrow pseudo-pedicle. These are the multiple problems we face. The next, is it again moving forward? Is it only the static compression which is? No, it can be a dynamic compression of both neural and vascular element involved, not just the bony issue compressing on the spinal cord. This patient came with imbalance while walking, and he came with right cerebellar signs. And this was how the MRI looked. And this MRI showed the right side cerebellar infarct. So we investigated further. This patient had what is called as Bow-Hunter's syndrome. That is, on rotation, there will be a compression of the vertebral artery. And this is a reconstructed image. And we did a flexion extension DSA, and this is the image of it, which shows that dye is not moving up, there is a compression. And this was also associated with partially fused C2, C3, and we did the foramen magnum decompression and distraction and realignment. And again, similar to the last, they had a progressively worsening quadriparesis. Then there was an increased lordosis. Similar to the previous case, we included subaxial spine, and the patient was all right. So we should look beyond dense. In fact, sometimes we may have to look beyond CV junction to see where is the pathology. The above case illustrates the complications. And these are the CT reconstruction images of the vertebrogram. This is much more useful than DSA in many a times, especially if you are using instrumentation. So we should always have an open mind and innovation. And these are the phases, most of it know in the mastery, and it is in CV junction, it is more true than in OBG. And the evolution has moved from just posterior fusion, transoral, now pre-op distraction, reduction, fixation. And Professor Atul Goyal from Mumbai, he has put in a fresh perspective. He has moved from dense, what I showed in the highway, what is the easiest or what looks obvious is not a pathology, to a lateral, that is the joints, that is the Maya. The shoe doesn't do any harm. And how I'll prove it again. This is a 14-year-old AAD patient who came as usual. This was one of the first cases we did with a AAD. Then at that time, we were not doing posterior fixation. We did a transoral odontoidectomy. 6 months back, she came with worsening of the gait. Then what happened, what went wrong, we studied. Here, what has happened is odontoidectomy is adequate, but the remaining stump has moved in. That is how it is, because the joint is the culprit, the inability, instability persisted. So the remaining stump invaginated, it started compressing the CV junction and patient worsened, especially since she was a small girl. And then, as you see in this lateral view, very clearly the stump has gone in. And what to do, that is when we learned about this technique. We went to the lateral joints. At that time, even the spaces were not available as freely as it is now available, thanks to Professor Goyal. I think patent also he didn't acknowledge. So here, once we did a opening, we could see the wire itself had cut through. That was where, if it was stable, if the procedure was stable, this construct was stable, then there's no way this could have happened. So the movement was still going on in spite of the fixation. And then using bone as a spacer, we distracted and fixed. This patient, we did it almost 2011. The patient had come for follow-up. She is still doing very fine. So there is little change from the classical technique which is described. We use head pins instead of traction or horseshoe. That is, of course, you can use it according to your convenience. We find that because there is during surgery it won't be manipulated much. And some of the problems we encountered, the vertebral artery may be very close to us. This is a classical paper which shows vertebral anatomy relations in multiple cadavers and others. That was one of our ways to study and gain into exposure. And similar to, far lateral approach and other where vertebral artery is exposed, here we can microsurgically expose the vertebral artery and then preserve it. And of course, we need not fear it, and we need not always look for it. And where it is very difficult to do it, we can use laminar screws for C2. This is one of other techniques. And to appreciate better, this is one of the elderly patient with a rheumatoid arthritis, hypermobile joint. And what had happened in this, again, apart from classical CV junction, mobile AD, she had occiput and C1 instability. So this is where we used condylar screws and C2 and C1 screws. And this is how it is pre-op and post-op. She is doing well. This is the intra-op images. And this is one of the last challenges. Or of course, there can be many. Syrinx is cherry or whatever is the culprit. This is one of the first cases, a 16-year-old girl. She came with syrinx and cherry malformation, and we at that time did foramen magnum decompression and duroplasty as it was. Then after some time, that is, she worsened. Then was subclinical instability a cause? We looked around, and that was when the literature had come. And then we decided to fix it. Then because already foramen magnum decompression was there, intraoperatively was adequate. We didn't do anything. We didn't open the joint. We didn't open the dura. We didn't disturb it. We just did the occipital C1 fixation. Now she is doing very well. You can see the intraoperative image, post-op image. The syrinx has almost disappeared. Almost we have 8 to 10 of such patients who have failed previously foramen magnum decompression duroplasty. We have treated with just fixation, and most of the syrinx have disappeared, or symptomatically they are much, much better. Even just 2 or 3 months is adequate. And in conclusion, there are multiple options available. The good understanding of anatomy, physiology is the key. Though technically demanding, our results are encouraging and they improve quite well. And thank you very much. We need to look beyond things to see what is there. Thanks. I'll be happy to take any questions and comments.
Thank you, Dr. Kiran, for enlightening us these complications of such a complex problem and emphasizing the opening of the facet joints and bony fusion in such cases, which Dr. Atul Goel has been harping upon, and also about the foramen magnum decompression and duroplasty in cases of ACM and syrinx, where fixation he has been advocating, Dr. Goel. But my question is, in how many patients of these ACM with syrinx do we need fixation? Dr. Goel probably says that all the cases probably are because of the instability. In how many cases do you see such thing?
Frankly speaking, after seeing about 6 to 8 cases which you have record after doing only foramen magnum decompression, nowadays all patients who come with the foramen Chiari 1 with extensive syrinx, I advocate fixation in all cases with syrinx.
Dr. Goel, for his comments.
Kiran, that was wonderful presentation.
Thank you, sir.
As you know, and as we all know, and that is why probably we have collected for this conference, craniovertebral junction surgery is absolutely dangerous and difficult. But if you know how to do it, if you have your concepts clear, if you have your philosophy clear, and if you are able to do it, you are able to give a new life. And that is the power that you have. And that is the power we all should have. There is no question of arguing and discussing. What we have to learn is how to do it, how to open the joint, how to do atlantoaxial fixation, how to put the screw. It is not easy, as you have said. And there are various permutation and combination which happen, and then you have to be open to all those permutation and combination. So as regard your various cases that you have shown and what difference is there in my own protocol, one is, I'm not trying to blame you or I'm not trying to criticize you. I'm appreciating you and want you to go further in this. But what different I do is that I have completely and entirely stopped doing occipital inclusion of the occipital bone, completely for a long time. And what you showed in the first case where the cervical curvature had changed, and then you did a subaxial multi-level fixation, I have completely abandoned subaxial fixation in craniovertebral junction surgery. What is required is, and even the spacer that, as you know, we had described long time ago, I seldom use spacers now. Particularly in cases with Chiari malformation and syringomyelia, Hemant had asked whether how many patients I will do of Chiari and syrinx or Chiari or syrinx, 100%, and without confusion and doubt. And the other thing is you cannot get 100% result in appendix operation, you cannot get 100% result in hernia operation, but if you get a good case of Chiari and with syrinx, with basilar, without basilar, 100% is the answer. And there is no 99%. Question is only one, whether you are able to do it. Instability is the issue. Distraction is not really necessary. Like introduction of spacer is not actually necessary in these cases. What is required is open the joint, introduce a lot of bone graft within the joint cavity, and then do a solid fixation. If you are able to do it, you will give new life. And if you are not able to do it, and if you are not aware of how you are, then you will keep on arguing and discussing, no, it is useless, no, I do decompression, it is good. The question is, arguments are far and finished now. I am not talking on 2 cases or 10 cases. I am now talking of more than 450 cases consecutive where I have done fixation only atlantoaxial for Chiari and syrinx. And 100% is my result. There is no doubt. In my phone, if you have time, Hemant, I want to show you. On my phone, there are more than 350 videos where the patient says, doctor, I have got a new life. So there is, in my mind, there is no confusion. I know time is an issue, otherwise, I cannot be stopped by.
Thank you, Dr. Atul.
Thank you.
I
Thank you,
think,
sir.
Thank you, Dr. Kiran.
Thank you, sir.
We'll move on to the next talk on management of odontoid fractures by Dr. Gopal Krishna, who is Associate Professor of Neurosurgery at PGI Rohtak, Haryana.
Good afternoon, Chairpersons. And I am getting goosebumps in front of CVJ giant, Dr. Atul Goel, and my teacher, Dr. Deepak Gupta, whom I have like assisted so many cases during my residency. And now I'm presenting this talk in front of giant Dr. Atul Goel and Sushil Patkar, sir. As already has been commented by Atul Goel sir, the divinity of the odontoid process. So I would not go and talk that it is a curse for the humanity. So embryology, the tip of the odontoid is derived from the fourth occipital sclerotome, and rest of the dens we all know that it is derived from the first cervical sclerotome, and rest of the dens is from the second cervical sclerotome. So this is the shivling here, as described by Deepak Gupta sir. And we can see there are two primary lateral ossification center and one secondary ossification center, which the primary lateral ossification center, they fuse by 5 to 7 years, and the secondary ossification center, they fuse by 12 to 13 years. So in the sagittal cut, we cannot see usually all the ossification center, but axial, we can see here there are two ossifications. The two ossification centers seen in the axial cuts. Is it being displayed there? Two ossification centers seen in the axial cut. This has already been described, so I want to go ahead. This is we can see in the coronal cut. We can see in the coronal cut the secondary ossification center is radiolucent and is not seen. But the same is seen when we see an axial cut at a later age. This is a secondary ossification center, and these are two primary lateral ossification centers. So coming to the vascular supply of the dens, there are many arteries and apical arcade is there, and ascending and posterior, anterior ascending and posterior ascending vessels are there from vertebral artery, and there are also branches from the ICAs. And there is one paper which described vascularity of the dens in a very good manner, and they also found anterior horizontal artery, and which are superior, posterior, both at the anterior aspect of the dens and the posterior aspect of the dens. So this one is the superior horizontal artery, which is coming from the ascending pharyngeal, and this artery arises, anterior horizontal artery also arising from the ascending pharyngeal arteries. This is the inferior horizontal artery, again from the ascending pharyngeal artery, and these are the anterior and the posterior ascending arteries from the vertebral arteries. So this is the posterior aspect of the dens, where we can see again superior and the posterior horizontal arteries, and these are the anterior and posterior ascending arteries from vertebral. So the base of the dens is has got less bone density. That is why it is very prone to fracture, and which is clearly seen in this image, which shows the bone at a younger age and the bone at an elderly patient. So there is the bone density is markedly reduced at an old age, and this shows the watershed area at the base of the dens, because this has got the least of the blood supply. Again, comparison of odontoid of different age group between 20 to 40, 40 to 60, and 60 to 80 years. We can see as age progresses, the bone density goes lesser and lesser, making it more prone, elderly people more prone to fracture even with a trivial fall. So as far like history goes, in 1910, Mixter and Good, they described a odontoid fracture, and they described what they found during their studies. And in 1928, Osgood and Loon, they described a series of odontoid fracture, and in their study, they found that odontoid unification after fracture is very, very rare. So odontoid fracture, they comprise around 9 to 15% in various literatures of all the cervical spine fractures, of which the type 1 is very, very least prevalent. We hardly see type 1 fractures in our practice. However, type 2 is very common, and type 3 is next in the line of odontoid fractures. And the incidence of odontoid fracture is rising, as found in the various studies all over the world, because of the increased longevity of people. In elderly, the fracture is even after the trivial fall, and because of RTAs also. The mechanism of fracture is mostly hyperextension and also hyperflexion. And presentation-wise, people have bimodal presentation is usually seen. In younger population, the injury is mostly because of hyperextension injury, and older patients, usually it is because of low velocity trauma and maybe trivial fall also that leads to type 2 or other types of odontoid fractures. So this is a classification given by Anderson de Alonso in 1974, which described the type 1 fracture as the fracture of the tip of the dens, and type 2 as the fracture at the base of the junction of the dens and the body, and type 3, any fracture which is extending into the body of the axis, it is a type 3 fracture. So this was further modified by Grover in 2005, which described type 2, A, B, and C, according to the line of the fracture, how it presents. So type 2A is the horizontal line, horizontal fracture. Type 2B is anterior-superior to posterior-inferior direction fracture. And type 3 is anterior-inferior to posterior-superior with little bit of combination at the base of the fracture. We should have very high index of suspicion for the fracture, and that's why we should be very, very prompt in investigating the case. And open mouth view, lateral view, CT, and MRI are indispensable in diagnosing this condition. Most of the indication in this surgery are if the displacement is 4 mm, angulation greater than 10 degrees, smoking, and age more than 40 to 50 years, and if there is any posterior displacement of the fracture, or if we have kept any person in conservative treatment and there is further malalignment or displacement which is worsening in follow-up, we should go ahead with surgery. So coming to the management of type 1 fracture, we all know this has got least prevalent, and there is no controversy in management. Usually with cervical collar, it usually fuses by 3 to 4 months. So for management of type 2 fractures, there are two approaches, anterior and posterior, of which anterior approach is anterior odontoid screw fixation, anterior C1, C2 fixation, and anterior transarticular fixation. And posterior approaches, we all know Goelser's technique, then transarticular posterior technique, and to complete the list, Brooks, Gelly, and OC fixation, usually described in some of the pediatric patients. Odontoid screw fixation was first described by Nakanishi and Wohler in 1982, which they described that with odontoid screw, fixation rates were very high. So what are the advantages of anterior odontoid screw? First is it gives direct fixation of the fracture, and it preserves the anatomy of the dens and the body, and it also preserves the mobility at the C1, C2 joint. And most of the patients, they report that they have immediate pain relief on the day of surgery itself. So coming to the technical nuances involved in the odontoid screw fixation, usually these fractures are dislocated, maybe anterior and posterior, so we need to put a preoperative traction. And this traction helps to maintain the alignment of the fractured segments. And we always advise for fiber optic intubation in such cases, and ET tube should be pushed to the opposite side depending on the handedness of the surgeon. We should always place cork in the mouth so that the mouth remains open during surgery and we can have a very good view intraoperatively of the odontoid. We should always use 2 C-arm, or maybe we can always also use O-arm or isocentric fluoroscopy, and it may help us in navigation-guided screw placement. And we can also pre-plan the trajectory when the patient is on the OT table before prepping up, and we can have a fair idea how to go ahead with the odontoid screw fixation and how would be the trajectory intraoperatively. Incision depends on the same. The wire will also tell you where the wire is touching the skin. There, that point you can give incision, but mostly it is between C4 to C6. And the incision side but depends on like how is the chest of the patient and any chest deformity, obesity, large breast of the patient. So these things will also determine where to put the incision. So good platysmal dissection is very important as there is lot of retraction required in this surgery. So and another thing is like do not keep on cutting the ALL and exposing all the vertebral body during cervical dissection as we do in ACDF. So just find the C5 body, and once you are there, you keep on ascending upstairs and you reach to C2, and there you take a shoot, and there you cut the ALL and part of disc for the screw head to fit there. The bicortical fixation is definitely preferred, but be very careful when you are tapping the distal fragment, and do not tap at the distal fragment. So this is the OT setup, and the O-arm is very helpful nowadays, and C-arm you know how to place so that the odontoid is visible intraoperatively. So this is a patient maneuver, how to achieve reduction intraoperatively if you have not placed traction. So K-wire is being placed preoperatively, as you can see in the first photograph. And this K-wire touches the skin, and you will have a fair idea where to put the incision. And you will also know how the trajectory will go intraoperatively, and you will have a fair idea how to put the screws. This is the K-wire preoperatively, and then all the intraoperative photographs. This is another case. You have to be very careful when you are withdrawing the odontoid tube. So when you are withdrawing the odontoid tube, you take artery forceps and you hold the K-wire you have to hold it very properly so that it doesn't slip and go back into the medullary canal. This is a lag effect already discussed by Deepak Gupta sir. So what if like we go into a wrong trajectory? So if you go into a wrong trajectory, take a paramedian position, and from there you start with a new trajectory. If you go with the same old trajectory, there are high chances that you will keep on hitting the same wrong trajectory again. So better to use a new pilot point. Pilot hole, you make a new pilot hole in paramedian position, and then you make a new trajectory. Second option is you do anterior fixation, C1, C2, or anterior transarticular, or you, if nothing is possible, you go posterior. This is one of the paper which describe anterior transarticular screws. How to do that? So you just shift your odontoid to 5 to 10 mm laterally, and from there, the odontoid tube is just move 5 to 10 mm laterally, and from there, you find the groove of the C2. If you go 5 to 10 mm lateral to the midline of the C2, you find a groove there. And from that groove, you can immediately place a transarticular K-wire, which will be directed towards the center of the lateral mass. So if you do that, you can easily put it anterior transarticular screws. So this is the same depiction. So this was one of the case. This patient is a young patient who came after 6 months after the injury when he had persistent neck pain. So what we found, there was a fracture of the dens. So we did a C1, C2 fixation because it was more than 6 months. So and after 8 to 9 months, this patient comes with a discharging sinus over the cervical region of the back. So what do? Because it was discharging pus there, so we tried to, we got a CT also, and that CT surprisingly showed that dense fracture has urited. So that forced me to look into the literature. We found one literature where it is shown that most of the people, these authors, what they did, in most of the people, they did temporary fixation of the odontoid fracture from posterior side, and after the fracture was united, they removed the implants. So this has also been discussed by Deepak Gupta sir. So my idea is, and there are few literature also which support this, that if you are putting 2 screws, not only in Indian population, if Indian population also you can put 2 screws in selected people. However, if you are putting 2 screws, the surface area for the union to occur, it reduces dramatically if you are putting 2 screws. So that is one of the thing which forces us to place only 1 screw. And moreover, if you put more screws, it will lead to more dysphagia, more throat discomfort in post-operative people, especially a person like me or some elderly people. So what are the causes of new union? Usually soft tissue interposition, and a patient is a smoker, inadequate immobilization, displacement higher than 6 mm. So these are the contraindications which we have already discussed. So this is one case where there is comminuted fracture of
Paul,
the dens.
can you run them fast?
Sir,
and
I'll take
conclude?
1 minute. Yes, sir. Yes, sir. So this is one of the case where there was comminuted fracture of the dens itself. So in such cases, we have to do a posterior fixation. And why anterior odontoid screw is not advised type 2C fracture? Because the fracture line is parallel to the screw will go parallel to the fracture line. So interfragmentary compression is very poor in such cases. That is why we tend to fail in this. So this is one of the case where I did after a fight with our senior, and I did an anterior trans odontoid screw in type 2C, and after few months it failed. You can see the screw pull out, and this fracture also didn't fuse. This is one more case where we placed anterior odontoid screw fixation, and after 8 months it didn't fuse. So we did posterior, but we did not remove the anterior odontoid screw. So in one more osteoporotic patient, I again placed this one, and it again showed screw pull out. This came out. So anterior versus posterior, I know Atul Goyal sir will always favor posterior, and in literature also posterior fixation has got higher rate of fusion. However, in elderly people, there is no clear-cut consensus which approach to use. So in elderly, it is highly controversial, although the aim is bony union or fibrous union. These are cervical immobilization options. So what if like a person is more than 75, 80, and if the dens is not getting fused? So is there any problem with that? Most of the people, we have found that there is no problem with such patients, and they carry on in their life. And whatever problem occurs, it is because of the old age and associated comorbidities. So what if we place halo or cast in these patients? So many people have found, many authors, they say that halo-based immobilization increases early morbidity and mortality in elderly patients with odontoid fracture. And to the extent that some of the authors have also said, if you are doing halo-based immobilization in elderly, it's kind of a death sentence for these people. Again,
Gopal, you have to conclude.
Yes, sir.
Short time. Please conclude.
Yes, yes. In elderly patient, however, there are few papers which have advocated if you do age-wise age group, that if 65 to 75, if you do surgery, there is survival benefit. And as the age progresses, 75 to 85, the survival benefit comes lesser. And 85 plus, whether you operate or you don't operate, it doesn't give any benefit. Thank you, sir. Thank you.
Thank you. Gopal, we will take up questions after Sushil Patkar's talk, because he is also going to talk on odontoid fracture. May I invite the next speaker? Next speaker is Dr. Rohan. Going to talk to us on post-residency fellowship. Is it worth?
Sir, Dr. Patkar is the next speaker.
No, as per the program, it is Rohan. Rohan there.
He is the last speaker. Before him, Dr. Patkar. Perhaps there is some printing mistake there.
It is the other way around. Okay, fine. Okay, fine. Welcome, Sushil Patkar. You have come back from Blackpool. You are not looking black.
I am dazed. I am dazed and confused. I've just flown in from Manchester. I've not slept, and also had a boxing match. And can you connect it? And I had a boxing match there, you know. Yeah, okay. So there was a boxing match in Blackpool, so I'm still not fully conscious. No disclosures, only gratitude, teacher and my beloved wife, my anesthetist for last 35 years. I don't get tired of speaking this again and again. So odontoid fractures, the previous speaker and everybody talks about this classification of Alonso, but this classification is incomplete because it does not discuss ligaments, which is the most important aspect in treating odontoid fractures and other associated fractures. There is a big complex group of fractures where there's a lot of instability. Some of them are irreducible, and these irreducible fractures are very, very treacherous. If left alone, they are going to end up in devastating neurological deficit. The cruciate ligament, always the longitudinal part fractures, disconnects at the lower end, and therefore you'll find in most odontoid fractures, the peg of the odontoid moves with the atlas. Whether anterior or posterior, not important, but it is always with the anterior arch of the atlas. So there are, people talk about transoral odontoid excision. I will not spend time with the standard treatment. I will go on to a new concept which I put forth. And people do transoral odontoid, then they do 3-stage operation, etc., or they do posterior fixation. Why do we operate odontoid fractures? We operate odontoid fractures is because if we don't operate, even if there is no instability, there is avascular necrosis, the distal peg will become smaller and smaller and smaller in size, and there will be sudden instability and patient can die. That is why we operate odontoid fractures. Or they will go into malunion like this, and that will give rise to cord compression. So there is a consensus, yes, they should be operated, odontoid fractures should be operated. But what operation should be done? After 2014, there has been no RCT. There is no evidence. Actually, people are doing what our seniors were doing, what our teachers were doing, and it is going on. If you see all the recent literature, it focuses on type 2 odontoid fractures in elderly people in the Western world because their longevity is more. Odontoid fractures in elderly is very common there. In our country also it is common, but there is a big group of odontoid fractures where there is instability is the issue and displace, because this to fracture a young odontoid bone, it requires great force. The ligaments have to be disrupted to give rise to that kind of fracture. This slide you saw, where the odontoid changes with time, but the cortex remains intact. What happened? Hello? Okay, fine, I don't want to touch that. So you have to understand, if you go look at the principles of orthopedics, odontoid is not a weight-bearing bone. And a non-weight-bearing bone, an intramedullary screw, is a wrong option. Wrong option. Humerus, you don't treat with intramedullary screw. Unlike femur. Humerus, you treat always with plating. Doing posterior C1, C2 fixation does not promote fixation of the fracture, it only holds it in place. And in displaced fractures, which are irreducible, it is not a good option. So what are the limitations? When you do this odontoid screw, you cannot add graft. Patient with short necks, it is not possible. Cruciate ligament has to be intact if you want to do an odontoid screw. The fracture line has to be correct, either horizontal or posterior inclined, so you can pass the screw. So odontoid screw fracture, I saw some slides where you said they show that the screw failed. I think the most important thing when the screw fails is because you don't have adequate bone in front. The screw has to countersink into the bone, and the distal end of the screw has to go beyond the cortex. This is orthopedics. If you don't do this, your screw is doomed for failure. And to do this kind of thing, you have to first violate the disc at C23. You violate the disc at C23, only then you can do this. There should be adequate amount of bone in front of the screw. So there are too many requirements for odontoid screw. The screw must be perpendicular to the fracture, or else you will end up in this kind of situation, where as you pass the screw, it will further dislocate. Now this is an example how the screw has not gone beyond the distal cortex, doomed for failure. And these are other examples from literature and what you showed. Then of course, Dr. Goel's technique for doing it from behind. So when you suspect that the ligament is disrupted, when there is facetal malalignment, when there is comminuted fracture, when there is a displaced, impacted fracture, these cannot be treated by standard operations. Now look at this kind of case. You might say that this is a type 3 fracture which can be treated. This fracture is going to go into non-union. The facet, again, principle of orthopedics. In a joint, if a fracture is entering into the joint, that means that fracture is potentially going to create trouble. So this was treated by this technique of, going and putting a plate across, and you can see over a period of time it has fused, and you can see on flexion extension how it has fused. This is another example. This is a horizontal fracture. Bad for treatment with a screw. You can't pass a screw because it is anteriorly inclined. So new concept, direct open reduction and fixation of the fracture. VSP, any fracture you want to treat, your technique must cause compression at the fracture site. And if there is instability and ligament is disrupted, then you must be able to fix the atlantoaxial joints. And that must be done at the same sitting, Now look at this example. Whenever you put this patient in extension, it is dislocating further and further. So this was treated with a compression VSP plate. You can see this. And you have to note that the screw has to go beyond the posterior cortex. Only then you will get good fracture healing. The odontoid should be remodeled. This should be the end point of your operation, that at the end of 6 months, you must be able to show that the odontoid has been reformed. If you cannot show this on the X-ray, on the CT scan, then thank you very much. See another example. And then this is how you reduce them. You put the osteotome, you correct it, bring it back into position. So this is the implant made for me by Jeon. They have made this kind of VSP plate. And this is the concept. Cannot be given by standard operation, odontoid screw or posterior C1, C2 fixation. This is the concept, that when you pass the screw close to the edge, you have to compress it. It should be passed up to the posterior cortex. This is just an animation. But it will compress the fracture. And then if there is instability, now look at this kind of fracture. Gone behind the fracture. This would have ended up the longitudinal component of the patient is disrupted. This patient will require transarticular screws. And this is how this passed to the front. And you can also hold the odontoid and bring it into position the way you want. So these are some examples. You can see this. Gone behind, so it is reduced, and then transarticular screws are used for fixation. Another patient, you can see this, how it is repositioned, and how the fracture has healed. And another patient, and this has to be the end point. If you cannot see this at the end of 6 months, your operation, principle of your operation is wrong. And another example. So this was the construct, anterior VSP plate with bilateral anterior transarticular screws. Another patient, you can see this displacement. This is the construct. Another patient, displaced. This patient had come to me late, but still by doing, you can see this, It's reduced, repositioned, and then the screws are passed, the plate is passed. This is another patient where there was associated Jefferson's fracture, and another patient where because of the hangman's fracture, I've also done an anterior C2-3 disc. This is another patient. And another patient. So the end point of odontoid fracture treatment is that odontoid should be reformed, and if there is instability, you should have fusion across the joint. And if you have not got that, then the treatment is incomplete. Now, this photo is there on Dr. Goel's, he's the talk after me, on his book, that patient came to me. And I operated the patient, this locked facet. And this can be done very beautifully from the front. I'm joking, huh? You just cut the longus colli muscle, impale the odontoid, bring it back into position, and you can see this. You can see this is how it impaled the odontoid from here, brought it into position. You can see the graphs, and you can see over a period of time, the fracture is fusing and healing. Another patient with a displaced odontoid fracture. Now, this kind of patient who's got a fracture plus a bad hangman's fracture also, these patients would have ended up in occiput C1, C2, C3, C4, C5, C6. I don't know how long they keep on putting these implants. So this is done with a very simple, through a small incision between the muscles, without disrupting the posterior tension band, going like an anterior cervical fusion, just with your finger and fusing, and see the end point. This is the end point in flexion extension. So that should be the way how you treat these fractures, and see, after 6 months, his movements are completely free. So instead of doing big, long implant from behind, keeping him restricted for the rest of his life with an internal halo, I think this is a much simpler option. Another patient here, this Jefferson's fracture, it has got a unstable Jefferson's fracture. And this is how it is treated with the plate, compression at the fracture site. So the classification is incomplete, and you have to think of so many things before you try to treat odontoid fractures. This, of course, got published. It's direct compression, reduction, fixation, new technique for treatment of odontoid fractures, and then in operative neurosurgery, subsequently in operative neurosurgery. So instead of going from behind and destroying this, this is the ligamentous complex which is holding the skull and the cervical spine. You go and just disrupt only this much. Biomechanically, it is a superior operation. Posterior surgery adds insult to injury. New option adheres to the principles of fracture treatment. There's direct treatment of the fracture. This is orthopedic principle. A single operation for treatment of any kind of fracture. No risk of injury to the vertebral arteries and a flat. You are all neurosurgeons, done so many cervical fusion. This is anterior cervical fusion, nothing else. The fixation has to be along the force nucleus, the line of weight transmission, and good quality of bone should be available. And technique should be simple. This has got published in JNS case lessons for all who want to know how the technique is done. The videos are there. Just last year, this was published. And the videos are also there in JNS, both for the posterior and anterior. I've got my own technique of doing posterior surgery by passing subfacetal screws, so you can study the videos, and they are freely available. There's no login, password, etc. required. And this came as a cover page article with this image of mine, you know. So message, fracture alignment and fusion are the endpoints. Fusion of the atlantoaxial joints is mandatory. Direct open reduction of fracture is possible. Anterior plate screw is quick and easy, and there is no risk of injury to the vertebral artery. Remember, truth will come sooner out of error than from confusion. Dogmatism, believing only one way to do it, is doomed for oblivion. I'd just gone, you know, I've got this connection with AIMS. You know, this was just 1 month ago, I was at AIMS to show how to do it, and I did a case there. Now, this is another patient, another technique of mine which got published. There's nothing to fix over here, and there's a pathological dislocation because of infection. And this is a new technique which I've described, where you transmit the weight of the skull onto the cervical spine. It is available on the net. You can go and see there's almost no bone oil because of fibrous dysplasia, and you can see this technique of how it transmits the weight of the skull onto the spine. And over a period of time with these biphosphonates, the bone is got fused. So it is easier to transmit the weight because the weight gets transmitted through the vertebral bodies. This technique is also published as a new technique of craniovertebral fixation. I will not spend time on that video. I'll show you another technique which I feel will eventually be the correct way of fixing. This I did for basilar invagination actually. And this had got published, and see how this has come down. And there's a screw which goes across, and there are 2 screws which go into the lateral mass with the distraction. The joint has been opened up and the bone graft has been put inside. So this was the plate which I made. After studying CT scans, I found that the average distance comes somewhere between 2.5 to 3.5 centimeters. So you make an array of plates, and this 3-point fixation is a very rigid fixation. It rigidly fixes an limb, but rather than having 2 separate fixations, you have a rigid fixation. There's a big bulk of bone available in the lateral mass. From the front, there is no fear, no discussion of navigation, no discussion of vertebral artery. And these are some examples you can see, you know. See this. Over 12 months. You can garden the joint, put bone grafts. And this is how it is done. I will require only 1 extra minute. And there is nothing, no impediment. You just go there, expose the anterior surface. I mark it with a micro drain. This is just showing for the video. And you mark the micro drain. Then get the plate inside. And you can pass a long screw of almost 28 mm. And only bone, nothing else. It goes up to the upper posterior lateral. And the central screw goes right up to the posterior end of the edge of the body. So this is the video of, how you will see it during surgery. The exposure is very, very simple, like anterior cervical spinal exposure. The drill holes are made under vision. You don't require the C-arm also. You don't require navigation. You don't require anything. If you have done enough anterior cervical fusion, this operation is a child's play operation. I call it child. It's an idiot-proof operation. So just a few taps. I do not believe in tapping too much. You should keep the bone intact. This is the plate. It is placed. And then These plates, on the table, there are usually 17, 18 plates. These two companies, they make for me. One of them is Geon, and they're there outside. I have no financial this with them, but they make whatever I want, whenever I want. But then you should not take any money, so then you can dictate your terms and you can shout at them. But once you take money or railway ticket or air ticket or hotel, then you're finished. So these are the examples. Now this is the new one which we are trying to make. But I feel that the lateral masses, they are very, very big blocks of bone staring at you to get fixed. And there's no struggle of discussion of vertebral artery and it is bleeding and that venous plexus is bleeding and the C2 root whether to cut or not to cut. All that becomes redundant. All that discussion is, waste of time. So this is the new plate which is come with a locking, a locking plate. All the 3 screws can be locked. So never be happy. Keep on asking yourself, is there a better way? Is there a better way? Is there a better way? Dumb people are happy. When you start off in C1, C2, it becomes like this, You can't understand. If you see Dr. Goel operating, you'll get frightened and run away. Then after some time, you'll feel that I know everything after you assisted him a few cases. Then you start getting complications and you start realizing, no, I don't want to do this. Then it takes time and then it starts making sense. And ultimately, you reach a plateau somewhere in between. The Goel is over here, I'm over here. Thank you very much, my dear friends.
Thank you, Dr. Patkar. You make things look so easy and so good. And we can understand that some people are interested in doing from front, some from behind, and both get the pleasure of doing it and getting the best of the results. The paper is now open for questions. Both the papers on the Odontoid. Dr. Suresh.
Very interesting talk, Dr. Patkar. Could you just tell us some of the complications or difficulties or something for the juniors to really understand?
The biggest complication, not being able to do it. Actually, that is a talk on anterior cervical CVJ surgery. I could not put it in odontoids. The biggest complication is if the mandible is not going above the C2-3 disc, then you cannot do that operation. It will be difficult. It can be done transorally. Of course, the Chinese, if you see the literature is studied with Chinese papers of doing anterior C1, C2 fixation, and they use a reverse tube plate, but they do it transorally, and they say that they have got very good results, and they believe that posterior surgery should be stopped, and they say that there is no infections in their transoral surgery. I cannot accept that. I do not believe in that. But for me, if the mandible is not going up, which happens about average about 10% of the times, then I would not do anterior surgery. The second thing is that if you, when you're younger, you tend to retract a lot and you can get a hypoglossal weakness or a marginal mandibular nerve weakness post-op, which usually is neuropraxia, and by 3 weeks it is out. Apart from this, implant failure in any implant in the body is destined to fail if you wait for a long time. And some implants can fail earlier. If anybody who says, who's putting implants in the body and says no complications, that person is lying to you or has not operated enough. The moment you put metal in the body, there's a certain amount of implant failure and you have to accept that.
Sir, good afternoon, sir. Always a pleasure to hear and always, letting us think about new topics. Just a query, sir. The plates that you use, you showed at the end, are these dynamic plates? So what is the...
They are not dynamic plates. Dynamic plate is a plate which can move.
Which can toggle, yeah. So this is like static
This is like a standard anterior cervical fusion plate that you use for subaxial spine.
And the second question is, do you advise immobilization after using these plates? And if yes, for how many months?
I always use a collar, a cervical collar, I feel, more for relief. See, whenever you have done any neck, I do not believe that you require the collar for holding the implant. The collar is for any wound goes through 3 phases or 4 phases. First is a stage of inflammation and deposition of granulation tissue, immature granulation tissue, then mature granulation tissue, and then finally scar formation. The first 3 phases are painful. So when you have a collar, the collar tends to take off a little bit of weight from the muscles because you have dissected, you have put your finger inside. The collar is not for supporting this plate. If you have done a good fixation, on table I always do flexion, extension, rotation before I start closure. Your implant should not move. Your screw should not move on table. Your hole should be good. And if on table, if everything is rigid, the collar is redundant actually. But it is for helping the muscles to heal faster.
Thank you, sir.
Sushil here from the chair. What a lovely talk always, no? Sushil, which is better, Dunning-Kruger or opposite of that, imposter phenomenon? Dunning-Kruger is immature fellows. They think they can do everything. And
I didn't get your point. I just repeat your question.
no, Dunning-Kruger effect means, youngsters, they think that they can get away by doing everything.
In the beginning.
But the opposite of that is imposter phenomenon, where, you are a good surgeon, but still, you are hesitant to do the procedure. Which is better?
I think in the patient's interest always, I believe that a hesitant surgeon does more justice to the patient than a person who's overconfident.
Okay.
I always believe that you should always begin with, I still invoke my teachers in my body, I always begin surgery looking at, I always say that, it's like Ravan. Ravan underestimated Hanuman and Hanuman burnt off his Lanka. Hanuman was small, for him a monkey, So never underestimate the operation and the patient's problem.
Next thing, only one mistake I found. That Giants you have put, Kerala spelling was wrong.
Oh, he has put it, not me.
You put Kerala.
I will shoot him. He's a Keralaite. He's a Mallu. And why is he put like this?
Put it Kerla. That is insult to Kerala.
He has
It is
put
Kerala. Okay.
I think Jeon should commit suicide here. He's from Palakkad, no?
Dr. Patkar, just one small thing that whenever you are retracting higher and higher in the cervical anteriorly, we used to see some of the esophageal injuries and fistula. So what is your...
There is no esophagus at that level. That is nasopharynx.
That is right.
And like I said, you were my senior and I was just a few years after you. During our time, all cervical spinal surgery was posterior surgery. We all took vows on the textbook of posterior cervical laminectomy by Charles Fager. And then Smith, Robinson and Clovart's work started coming in. And I went and told my teacher, Dr. Vengsarkar, that we must start doing surgery from the front. And he just hit the sea saying, you want to tear the esophagus, you want to break the carotid artery, the patient will die on table. But today nobody does that. Today everybody operates from the front. So I don't know why there has been this reluctance, because it was a little high up, because we did not do the dissections. If you do one cadaver dissection, you will stop doing posterior cervical C1, C2 fixation. This is my promise to you. You do one live, fresh cadaver dissection, and you will say that I don't want to do posterior surgery. And Dr. Goel will be out of business. Next.
I've been doing this technique for a couple of years now, and I've had difficulty in reducing locked facet from the front, especially in old cases, traumatic atlantoaxial dissection. I try to lock it, unlock it, and then sometimes I have to do an in situ fixation. I'm not able to get them in.
Read my paper in JNS, which got published last year. The answer is in that paper, how to do it.
I think we have to move
Sir,
on.
one more question, please. Sir, distal fragments, sir, you are putting anterior plates, okay, and the distal fragment screw is also placed. Sir, usually putting a screw in the distal fragment, because the dens does not have any posterior support. So what if like it translates posteriorly and causes damage to cervical?
The secret for doing good spinal surgery is first to use good instruments. You must have a good micro drill. The micro drill must be from Medtronic and Medtronic only. A good power drill. There is no second try. There's no second try. You use a good micro drill, you are going to drill into the odontoid. In the beginning, you can do it C-arm, or you can calculate on the CT scan the thickness of the distal fragment. And in the distal fragment, if you'll notice, I passed all the screws upwards so that I have a lot of bone to hold. I didn't pass the screws straight into the distal cortex. Whereas in the C2 body, I passed the screw straight down backwards. So it's not a problem. There's a lot of bone in the distal fragment in a type 2 fracture or a type 3 fracture.
What if like you are pushing the screw posteriorly, like say superior, posterior?
There are ways. There's one video I did not show you.
Sushil, you can discuss.
You can impale it and hold it.
Thank you.
We are 30 minutes behind time. We have inaugural function also post lunch. So we may call the last speaker. Is he around? Rohan, to talk on post-residency spine surgery fellowship. Is it worth?
Hello. Thank you, eminent panelist. I would like to thank Professor Deepak Jha and the organizing team to give me this opportunity. My talk is a bit off track after all the academic talks we have had. So I just finished my fellowship last month from AIMS Jodhpur in CVJ and spine. So my talk is more about the residents and the just passed out candidates. So post-residency spine fellowship, should it be done? Is it worth it or not? So first to quote Sigmund Freud, he was a great Austrian neurologist. He said that one day in retrospect, the years of your struggle will strike you as the most beautiful. Starting with that, this is an article published in Neurology India. It was published in 2019. It is a survey in the 5 major institutes in the country where they surveyed the residents about their satisfaction regarding their residency. No fellowship data as such is available, so I quoted from the residency data. So around 70% of the students who were quoted, they said that their subspecialty exposure was sub-satisfactory in all of these institutes. And I'm sure that if we go on to involve all the institutes, this would definitely go up. Post-residency fellowships, they have been started in few of the elite institutes. And this has also partly contributed to this dissatisfaction among the residents. And I would say it is vice versa, that the dissatisfaction have led to the start of these post-residency fellowships in the subspecialties. So this is a normal lifespan of a normal resident. You'd take around 5.5 years of MBBS, then his MS, MCH, and DNB studies. And if you add the drop years, it is always 30 plus the age when one reaches this stage that he has a degree in super specialty in his hands. So post-residency fellowship, specifically spine, is it worth it? Now, I would like to quote 2 examples here. Firstly, I think that post-residency spine fellowship should be done because majority of the neurosurgical centers in India, they have a cranial burden more as compared to the spine. Cranium takes preference over spine. That is for one thing. And secondly, orthopedics people, they are also involved in a great deal of spine surgeries. So the natural load of spine that comes to us, to the neurosurgery department, and in general to the resident, is less as compared to the other subspecialties of neurosurgery. So once we finish our residency, the reasons for pursuing a fellowship would be attaining clinical competence, increasing the confidence in whatever we have learned, attaining specialized skills, and if we want to pursue an academic career, we can vote for the acquisition of marketable skills and specific career goals. But my point of view, the main reason for pursuing a fellowship post-residency is the dissatisfaction in whatever subspecialty exposure that we have got during our residency. So if we go on for a post-residency fellowship, there would be pros and cons. The pros would be we will be able to do what we like. We have better hands-on in the specified subspecialty, spine in this case. We can refine our surgical skills, and we can have an in-depth knowledge acquisition of the subspecialty we like. But there are also cons. It's another 1 to 2 years of dedication post-residency. You're already enough tired of doing your residency and studies. Family pressure and continued compromise of the family and social life, that is a different perspective altogether. So if we plan for a post-residency fellowship, where should we do it? Should we do it in India or abroad? Each has its pros and cons. If we plan to do it abroad, then definitely we will have an exposure to a completely different set of cultures. We will have come to know about different technologies, skill sets, and thought processes. And also, it definitely broadens the perspective as compared to what we have learned in our parent institute. While the cons are, firstly, searching for a fellowship abroad is quite a tedious task. We have loads of formalities to complete for it and economic constraints. I would not go into the details. There are lots on the internet. And if we plan to do it in our own country, in India, should we do it from the same institute or a different institute? If we do it from our parent institute, then definitely we'll have the familiarity with the culture. Our teachers know about what our ideas are, what our strengths or weaknesses are, and can structure our fellowship accordingly. There's no difficulty in adjusting. While there are also downsides, the availability of fellowships, it is quite rare in India. And definitely in our own institute, we would feel like we are doing an extended residency. Eating juniors, cutting, that's a big perspective. I definitely consider that few of my colleagues and juniors would definitely go on with me. If we plan to do it from a different institute, then definitely, again, we have a different exposure to different techniques, new thought processes, while on the other hand, we can have difficulty in adjusting. Hands-on may not be as equivalent to someone who has done it from the same institute, because definitely the teachers would be new, everybody would be new. And again, the junior's attitude that matters. So once we are down to, if we decide to do a fellowship post-residency, we plan the institute, the subspecialty, and once and the duration we are decided upon, then we prepare for the entrance exams and all. That is another heck of a thing we go through. So my advice to my juniors and colleagues, that would be choosing a subspecialty of your interest is the most important. If you feel that you have not had enough exposure in something that you want to do later on, then that would be definitely the most prime of your list in choosing a fellowship subspecialty. You should seek out people who have been through courses. We definitely have contacts, seniors, and you can get a rough idea as to where should we go on for a fellowship. We should try to choose a balanced course. The workload and also our family and personal lives should go through old questions, ask seniors about the entrance patterns, and definitely we can go on to prepare for the exams and interviews accordingly. So I just finished my fellowship in CVJ and spine surgery last month at AIMS. Initially, I was a bit reluctant. Same thing, family pressure, peer pressure, and all the constraints. But finally, I decided upon that I would like to go on and do my fellowship here. So the first thing that I liked at AIMS Jodhpur was that the course structure, it was though not defined, but still I had a good, lots of hands-on experience. And in addition to that, a pre-operative presentations, they had a big role to play in learning about spine. And what we read in books and what we come across in the OT are definitely two different perspectives altogether. So just reading across a night before, coming and presenting, and then getting the inputs from the seniors that this is what happens actually in the OT and not what has been taught you or what you have read in the books. That definitely had a lot of impact on learning, which I had here. I would like to thank the department and Jha sir, definitely, for this nice experience. Thank you.
Thank you. Thank you very much for that talk, Rohan. Always doing a postdoctoral fellowship in the place you have studied. It's a known angel. A known devil is better than unknown angel. So do in the place where you have got training. But you correctly told it will cut the opportunity of the final year residents. But very nice talk. And to youngsters, three things in future for neurosurgeons they should do. One is spine, other is endovascular, other is endoscopy. The rest of the things will slowly come down. So that is my advice. And young neurosurgeons should go for the subspecialty fellowships. Okay. Any comments? Yeah, Sushil. So many people.
Yeah, this is very good what you said. But what I want to know, all of you know how to ride bicycle? You know how to ride bicycle? Everybody here knows how to ride bicycle? Does everybody know bicycle? What is the most important thing in bicycle riding? How do you learn to ride the bicycle?
Balance.
Balance. And a mentor to hold the seat, run behind you, and let go. But you are forgetting the most important thing is the bicycle also. You need a bicycle which can be dropped many times, which can be damaged many times. Fellowship all is useless until you are working and going to get appointed to work again and again in public hospital. Don't go into practice till the age of 40. Work in public hospital. You need the bicycle. Without the bicycle, seeing somebody else operate 20,000 times, clapping 30,000 times, no use. So, people say, I went to America and did this fellowship. Did what? Stood there and saw and came back. Unless and until you are in a public hospital back home and spent till your hair starts becoming gray because of the OT light, only then that fellowship has any meaning. So without a proper public hospital behind you, where you can come, work, learn, have some mentor behind you who's holding the seat from behind, just going, I see people traveling, they'll do one workshop here, one workshop there, one fellowship here, one fellowship there, but they have not had opportunities to work in public hospitals. So the most important thing in the bicycle riding is the old bicycle.
I disagree with Dr. Patkar at some point of the time.
Agree to disagree.
Yes, so the disagreement is do not jump on the bicycle.